So, hello everyone. So, you would have observed that the case control study, the first part was released almost more than a month back and it was pending. So, I decided to finish that particular topic. So, this is where we ended the first video, the story so far. So, in the first, what should I say, part of the video, we had seen the case control study definition. We had seen 2 by 2 table, and we had seen the 4 basic steps of case control study, which were selection of cases and controls, matching the overall conduct of study or the process of data collection named as measurement of exposure, and the analysis and interpretation, which included the various steps of analysis. That was measurement of exposure rates, that included estimation of risk, and also calculation of the favorite terminology, that is the odds ratio or the cross product ratio. So moving on from there, we are starting the part 2 over here. So firstly we have bias. So we would have heard about bias, and what is bias we would talk in detail in some other video. But for now, in short, bias is a systematic error. And obviously here we are talking about bias in case control studies. So in case control studies, this bias is a systematic error which affects the determination of association between exposure and disease. And it reflects some kind of non-comparability between cases and controls. So see, when you are asked about bias, or when you want to read about bias, or when you want to understand the concept about bias, bias in itself is a topic of its own. But here we are not talking about bias in general. We are talking about bias in case control studies. So when we are understanding bias in case control studies, it is very important that we understand that in case control studies, bias is a systematic error which would affect the association between exposure and disease, and it would make cases and control groups non-comparable or less comparable. Please remember, in the last video we time and again kept repeating this word association or strength of association, likeliness, chances. So this bias would affect that likeliness. So suppose you calculate the bias, the odds ratio to be 12, maybe due to one or other bias it is actually not 12, it is less than that. Rarely it can be more than that also, but generally when we talk about bias, we talk about an over exaggerated, odds ratio. So what are the various biases we are looking at as far as the case control study goes? So firstly, we talked about confounding in detail. Confounding is something which is related both to exposure and disease independently. So there would be biases due to a confounder or bias due to confounding. Secondly, we have a memory or a recall bias. So when you go and collect data to do the analysis, that in the process of data collection, when questions are asked, it is not necessary that all the subjects give all the answers with equal amount of commitment, or with equal amount of equal quality of recall, equal quality of memory. And generally, it is expected because there are more events that have happened with cases. Cases are those who have had some disease. They might have had a myocardial infarction or a COVID-19 infection, or their child might have had some teratogenic, event during pregnancy or as a result of pregnancy. So it is generally expected that the cases are going to give you better quality of information as compared to controls, and this is something known as the memory bias or the recall bias. Obviously, because the quality of information is different between the case group and compare and control group, the strength of association will get affected, and the comparability between the two groups will also get affected, which we saw on the previous slide. Third is the selection bias. So selection of cases and controls, we saw it in the first part also, is one of the most important step of this study. If that goes wrong, then whatever comes out of the study, the validity, the quality of that result will always be questionable. And if the cases and controls are not selected in a proper way, then a bias may arise. And with respect to selection bias, basically we are raising a question over something known as the representativeness. Representativeness. I won't write the whole word. Representativeness. What do we understand by representativeness? The cases. Suppose we are taking 50 COVID-19 patients at the start of pandemic. Some case control study was being done. At that time, COVID was a rare disease, so case control study could have been done. You are in April 2020, first week of April 2020, or last week of March 2020. 50 cases of COVID are taken and 300 controls are taken. Are those 50 COVID cases representative of all COVID cases in that city, state, country? And are those 300 controls representative of all those not having COVID in the same geographical area? Is what is meant by representativeness, and not being representative is what is meant by the selection bias. The next kind of bias is Bergsonian bias. So Dr. Joseph Bergsonian, I would advise you to remember this name. So Dr. Joseph Bergsonian has particularly defined this bias, that and it is based on the fact that the rates of hospital admissions are different for different diseases. They vary due to various factors. There may be various determinants. So when you take cases and or controls from hospital, then a special type of bias may arise known as the Bergsonian bias, and it is related to variable rates of admission to a hospital. So the take-home message from Bergsonian bias subtopic is that whenever you read a result or whenever you interpret a result of any case control study, you have to make sure what was the study setting. Was it a community-based study or was it a hospital-based study? If it was a hospital-based study, then I would say the quality of results are more likely to have various kinds of biases, and one of those is the Bergsonian bias. Finally, the fifth is the interviewer bias. Now, keep things simple and think yourself. If there are four chairs in front of you and four subjects are going to come and sit on those, and you have to, read out a questionnaire to each of them, and one of them is having the disease and three of them are not having the disease, it is but natural phenomenon, it is an obvious phenomenon that the one having the disease might be asked more in-depth questions, or the same questions would be repeated to get more information or a better quality of information as compared to three others who are known to have not have that disease, that is they are from the control group. So interviewer bias is when the quality of information collected is deliberately more from the case group or deliberately different from amongst the case group as compared to control group. Generally, it would be collected with more details or in more depth from the cases group. So these are the different kinds of biases in the case control study. Most important to remember that when we talk about biases in case control study, we are talking about errors, systematic errors that affect the association between exposure and disease, and they make the two groups, that is the cases group and the control group, they make them non-comparable or relatively less comparable. Okay. Moving ahead, what are the various advantages of case control study? So there it is easy, rapid, inexpensive, fewer subjects, no risk, rarer diseases, etiological factors, etc. and all that is okay. But whenever we are reading comparative terms like advantages or disadvantages, we have to first ask a question to ourselves: advantages of case control study over what? Or disadvantages of case control study compared to what? So whatever advantages or disadvantages we are going to see in the next three slides or so, they are generally in relation to or in comparison to firstly cohort study and secondly randomized control trials. So please keep that in mind. So when we say that case control study is relatively easy, rapid and inexpensive, it is relatively easy, rapid and inexpensive as compared to firstly the cohort study and secondly, as compared to what is known as the RCT, or that is the randomized control trial, or also known as the intervention trials. Okay. So similarly, fewer subjects are required and there is no risk to subjects is in relation to these two studies. I'm not saying that it would always be in relation to these two studies, but most of the advantages and disadvantages that we talk about are in relation to the two other big study designs, that is the cohort study, which is also an analytical epidemiological study, and secondly the RCT, which is an experimental uh, interventional epidemiological study design, which we would obviously see in the coming videos. For now, coming back here, case control study are particularly suitable for rarer diseases. So why they are suitable for rarer diseases? So these 2 points go hand in hand. That firstly, fewer subjects could be enrolled and you could get the odds ratio. And secondly, because in rarer diseases, anyways, it is difficult to get huge number of subjects, case control studies are more suitable for them. So suppose there is some genetic factor, some genetic disease, which happens like 1 in 1 million or 1 in 2 million or 1 in 10 million births. It would be phenomenally difficult to get a say a cohort of 10,000 or 50,000 of that particular disease. So in such cases, case control study designs are the ideal study designs to look back and look for a risk factor or a positive factor or whatever we are trying to find. Okay. Next is several etiological factors can be identified. So suppose you take a case group of 50 young women who have had heart attacks below the age of 35 years of age. 50 young women, I'm saying young because they are below 35 years of age, and they have had a one episode, at least one episode of myocardial infarction, which is very rare, even in today's day and age, where the NCDs is such an exploding epidemic among women, young women having obvious, myocardial infarction is still rare. So in such a age group, you can look for various etiological factors. So firstly, we are just taking an example over here. So firstly, for this particular study design, suppose you take 50 young women with a history of heart attack, aged less than 35 years of age, and we are comparing it with 200 comparable young women or 200 matched controls. So what are etiological factors can we look at? Firstly, we can look for a sedentary activity. We can look for, let us say, high carb, fat diet. We can look for presence and absence of smoking. Within smoking, maybe we can look also have a category, subcategory of number of cigarettes up to 5 to 10, and so on and so forth. We can look for consumption of alcohol. With the context of pandemic, maybe we can look for how many of those 50 cases had COVID in last 2 years or last 3 years, and how many of those 300 controls had COVID in last 2 or 3 years, because COVID has been on the basis of available literature, COVID has been said to have increased the number of thromboembolic events like myocardial infarction. And maybe you can look for the use of OC pills. So diet, smoking, physical activity, history of COVID, history of OC pills. So various etiological factors you are able to look at in this one case control study, which is 50 cases and 200 controls, 1:4 case control study. So that is one example of how several etiological factors can be identified. Now, because you are looking for several etiological factors, you can have rational prevention and control programs designed for a particular, a society group or an age group or a gender group or any particular subgroup. I mean, that can be done for the whole society as well, but especially where there is a small group having some extraordinary amount of disease, extraordinary prevalence of disease, rational prevention and control programs can be designed by the use of case control study. No attrition problems are there as there are no follow-ups. So see, this is where we are. This is where we are conducting our case control study. Now we are looking backwards. How much backwards? So in some cases, we might be looking for 7 days. In some cases, we might be looking for 2 months. In some cases, we might be looking for a one interval of pregnancy, that is 9 months or You can say maybe past 1 year or past 5 years or past 10 years. It can be as long as possible. But generally, all that information is taken in one sitting, basis of whatever is your case record form or whatever is your data collection tool. All this information of past also ever time period is taken in one sitting, and that is why loss to follow up or attritions are not words that are generally associated with case control study designs. So that is one of the advantage. And ethical problems are minimal. Again, please remember, when we say minimal, minimal in comparison to what? Minimal in comparison to cohort studies and randomized control trial. Simple example, start of COVID pandemic, year 2020, COVID vaccine trials were being conducted. Obviously, those which qualified for trials amongst humans, they might have had some beneficial effect in the animal models. So we know there is a vaccine. We know there may be some beneficial effect. How large is the beneficial effect? That is being quantified, but it is being given in RCT only to half of the subjects, and the other half are being given placebo. So is it ethically correct or ethically not correct? That is a discussion we will have in a randomized control trial. But such ethical problems do not arise in case control studies, because again, if we go here, we are here, and whatever was the comparison, whatever was the exposure in one group and whatever was not the exposure in other group has already happened. So we are not choosing or not choosing any kind of exposure or intervention or any such thing. And that is why ethical problems are relatively minimal is in case control study, particularly when you compare it against cohort studies and particularly when you compare it against randomized control trials. Now, there are advantages, so obviously there have to be disadvantages also. So again, what are the disadvantages of case control study? The first and foremost are the biases. And all the 5 biases which we studied are potential disadvantages, but particularly the important ones are memory bias and selection bias. And something I mentioned like 3 or 4 slides earlier also when we were talking about biases. Whenever we talk about bias, especially memory and selection bias, we are looking for the word representativeness. Are the cases representative of case group, and are the controls representative of the control group? So memory bias, selection bias, etc. make the representativeness less, and that is why they affect the comparability and they affect the strength of association. Now moving on to the second point. Now we saw in the analysis part that we don't have a denominator. Because we don't have a denominator, we cannot calculate incidence. And because we cannot calculate incidence, something which is not mentioned here, we also cannot calculate what is known as the relative risk. We have seen this in the first part. If you don't remember, please go back and revise that first part of the case control study. Because there is denominator is not present, incidence cannot become calculated, and because incidence cannot be calculated, relative risk, which is incidence of among exposed upon incidence among non-exposed, also cannot be calculated. So we take something which is a substitute of relative risk, and that is known as the odds ratio or the cross product ratio. So that is the second disadvantage or second major disadvantage of case control study. Thirdly, we cannot differentiate between causes and associated factors. So just taking an example which I took on the last slide, 50 young women having heart attack. We were comparing or we were collecting information about OCPLs, about diet, about smoking, about alcohol, about history of COVID, and many other factors. But whatever the odds ratio comes up for each individual factor, it would be phenomenally difficult to tag that this particular factor is the cause of that early age MI or early onset coronary artery disease, and this particular factor is the associated factor. That differentiation becomes very, very difficult in a case control study setting. And similarly, because this is a backward looking study, evaluation of therapy and prophylaxis, which we would generally start today and look for effect over next weeks, days, weeks, months, years, whatever, cannot be done in a case control study setting. Now, in modern day epidemiology, the study settings are not like completely theoretical. There are many improvisations. There are many, you have specialized study designs, and taking all that into consideration, using words like cannot be done or do not, uh, you do not get it, all such are like a bit absolute words which better be avoided. So that is why I have just a note to make over here that instead of using these words cannot, please read that it is difficult. So it is difficult to differentiate between causes and associated factors in a case control study design, and it is difficult to evaluate therapeutic and prophylactic procedures using a case control study design. So these are the major disadvantages of case control study design. Now, examples of case control study. So there are three examples given in our textbook. All these three are, I would say, remarkable examples. Firstly, let us take the example of adenocarcinoma of vagina and diethylstilbestrol. DES stands for diethylstilbestrol. It is an estrogen. So adenocarcinoma of vagina is something that happens after 50 years of age. But it was found that some young women started having this disease much earlier than the expected 50 years of age group. What is remarkable is that when a case control study was done, it was found that when these young women, listen to this carefully, it is interesting, when these young women were female fetuses in their respective mother's womb, and when the mother had taken diethylstilbestrol, that led to some changes, which led to an early onset adenocarcinoma of vagina. So please understand the study design and the output that the study gave. We are not talking that when girls have early exposure to DES, they are going to have an early onset adenocarcinoma of vagina. That is not when we are saying. When a lady takes DES in pregnancy, then if the fetus is a female fetus, that fetus, when it grows to become a girl and a woman, that particular woman, the second generation woman, will have an early onset of adenocarcinoma of vagina. And this is really a remarkable example of how case control study can, give us uh, a, a good quality scientific information. Similarly, when OC pills came into picture, they were like the king of the pharma world. 100%, almost like for practical purposes, almost 100% failure free, and there were no obvious side effects. They were thought to be pretty safe. They were rampantly used, only to be found later on that there was an increased association with thromboembolic events amongst young women, which we normally don't see, be it myocardial infarction, be it coronary artery disease, be it acute coronary syndromes, be it stroke. Two known risk factors are male and elderly age. So male gender and even in male gender, advancing age are two known risk factors. But when these events started happening, even peripheral arterial disease for that matter, when these events started happening in women of younger age group, and it was found based on case control study designs that most of these women amongst whom these events were happening were having OC pills. So how does science change? So because such a study was ever conducted and such a fact was ever concluded, that is why today we have something known as the mini pill. We have a low dose OC pill. We have biphasic and triphasic OC pills. We have progesterone only pills. Instead of pills, we have injectable preparations which give the drug only once and cater for like 2 months, 3 months. We have transdermal patches which have reduced drug delivery of estrogen and progesterone. And we even have hormone enabled IUCDs. So instead of just one hormone pill, which was so rampant and which was like so much advertised, was 100% contraception. Because of such study designs, we have so many improvisations over that. And that is how the science develops. And obviously, if these two have any lack of interest whatsoever in your mind and brain, then here comes the real game changer as far as the world of teratogenicity is considered. So this particular drug, thalidomide, now it is more of an obsolete drug, not very commonly used today. Even in your textbooks, you would right now see maybe hardly anywhere you would see. Maybe you will see in the treatment of lepra reaction type 2. But why was thalidomide being used in pregnant ladies? So it was claimed that it was a safe, non-barbiturate hypnotic. So in pregnancy, and especially early in pregnancy, when women have the symptoms of nausea, when women have symptoms of sleeplessness, when they have some mild discomfort. So for to reduce such dread and to reduce such fear, this particular drug was being advertised and this particular drug was being used, only to later having later being found that women who were using this particular drug in their antenatal period, their fetuses were born with particular kind of defect, which is known as the seal-like limbs. And a case control study was carried out, and it was found that women who consumed thalidomide, there was a strong association between the consumption of thalidomide in the antenatal period and the presence of seal-like limbs. Again, see today when you see if a mother is diabetic, you would change over from oral agents to insulin. If a mother is on TB treatment, there are considerations of how TB treatment should be, modified if there is pregnancy is present. Never mind diabetes and TB, even in simple infections like urinary infections, like chest infections, like throat infections, what antibiotic can be used and what antibiotic cannot be used, there is a consideration over that if the lady is pregnant. There is consideration about radiological procedures in pregnancy. There is consideration about simple drugs like simple, aspirin and paracetamol and pantoprazole and cetirizine, and all those drugs have a ranking. There is something known as a classification of pharmaceutical products based on the teratogenic potential into class A, B, C, D, X. Now, I don't say that this only one particular study is the base of all this, but this was one of the game changer event in the field of teratogenicity and how the external factors like radiation, like drugs, like infections affect the growing fetus in the mother's womb. And this study has thereby contributed a lot to the considerations of usage of drugs whenever a female is pregnant. So three landmark scientific events, and all of these three are examples of previously conducted case control studies. Now, moving forward, I thought we would have a couple of questions. So, firstly, I thought we would solve it, but later I thought better way would be I am just narrating the questions right now, and maybe in a later video, maybe 1 or 2 weeks down the line, we can solve this. Till then, you try on your part to solve it. And if you are interested, please do let me know if you got the answer and whatever answer you got in the comment section. So I'll read out the two questions to you. The first question is very simple. You have to calculate the odds ratio. Now, what is given? So the cases is seal-like limbs, controls is normal limbs. The exposure is thalidomide present, and the exposure absent is obviously thalidomide absent, and these are the total columns. Okay. Now, remarkably, only four figures are given. So seal-like limbs amongst thalidomide present is 41. Normal limbs thalidomide present is 1. The total is missing. The whole second row is missing, which makes it look like this problem is impossible, but believe me, it is not. And in total, we have total of seal-like limbs is 46, and the overall grand total of study is 346. This obviously would be the total of 4 cells, 346. Now, just as a hint, I'm sure you are obviously very smart and you would be able to solve it. But just as a reminder, we are not worried about what is missing in the table. We are worried about odds ratio, and odds ratio is a cross product ratio. So please do try it, and whatever answer you get, do let me know in the comment section. We have 4 options also. First option is 10,008. Second option is 54. Third option, that is option C, is 2452, and option D is 267. So at least you can comment A, B, C, or D, and it would be interesting to know what answers you get. Now here we don't have a table, but we have a very, very long text-based question. In a case control study, 100 young women who had history of myocardial infarction were enrolled. MI stands for myocardial infarction. Control group included 300 matched young women with no history of coronary syndrome. Out of 100 young women who had history of MI, 60 gave a positive history of using OC pills, whereas only 30 women out of control group used OC pills. So it would be very difficult to understand this question in the first row. So try to read it like 2 times, 3 times. Try to read it line by line. Hint is that you should start constructing your standard 2 by 2 table along with each line. Will make things easy for you. And the two questions involved are, if you don't remember, you'll have to go to the first video to look for what it is, or you can go to the textbook also. Calculate the exposure rates for both the groups, obviously the case group and the control group. And the second is calculate estimate of risk or estimation of risk of myocardial infarction in young women using cross product ratio, that is the odds ratio. So, bit of a homework for you, and I would be really interested in knowing how many people get it, at least solve it, and whosoever solves it, don't be afraid whether it is like right or wrong or not so correct or whatever. Do comment on this video and let me know what you got. It was really overwhelming to see that even though I haven't been able to put a video on this channel for last 2 weeks or so, the number of views in the previous videos have gone up. And on an average, there are around 30 views on all my previous videos. Thank you, all the viewers, for that. If you do like this video, don't forget to hit the like button. Do subscribe to my channel, and I can rest assured that be rest assured that there are many more interesting academic content coming up with relation to community medicine. Do share these videos with your friends who are like your co JRs or your co students for MBBS course or any course that you are pursuing currently. And do comment and do let me know what you feel can be improved or should be improved. Do you feel the video is too slow or too fast or too vast, or too narrow, a very short topic covered for a very long interval? The channel is open to all your comments and critics. So you do use the comment section to give answers to these two questions, and also do use the comment section to let me know how better we can make this channel for all of you. Hopefully, we will be back with obviously the answers of these two questions and also some other topic also in near future. Till then, thank you very much for watching. Have a nice day. Bye bye.